But they will tell you it's done on the second time. But now we do it when the patient has a bleed for the very first time. You go ahead and do this procedure because you're talking about the things that are going to keep the patient alive for the longer period of time. It's going to be doing that procedure. Okay, so that's something that's going to happen with the patient. So you also have to kit them, of course, to stop drinking, kind of thing. But during the acute phase, when the patient comes into you to a hospital, if a patient does have known varices, this is one of those things to do not just for testing purposes, but for your life as a nurse. If a patient is known to have varices and a doctor asks you to put an NG tube down, decline. It needs to be done by a physician under fluoroscopy. Because remember, those varices are there. If you touch one and rupture it, the patient starts to bleed. The reason you want to do it under fluoroscopy is because it allows you to visualize it so you can go around them and put down the tube. There is a tube that we sometimes put in for patients. We don't see it as much anymore, although it's still in your textbooks. I'll tell you about it. It's called a Stinson-Blakemore tube, or just Blakemore tube. And what that does is it's a type of NG tube, but it also has balloon on it, so that once you pass it in the patient, you know this patient is bleeding. So what you can do is it blows up, kind of like the plastic that we do for a cardiac cath, is it has a balloon on it, so you open up the balloon and it pushes the varices against the wall and stops the bleeding. So you can actually get like a tamponade effect. But because it's an NG tube, it also allows you to remove the blood from the stomach, which you need to do, because when you have a patient who has blood in their stomach, one of the byproducts of blood when it breaks down is ammonia. What does ammonia do to mentation? It makes you obtunded. So think about all those alcoholics. You ever notice that when you give them that lactulose, how much better they get? And it's because as you lower the ammonia level, the patient's going to become more alert. But if you just let blood sit there in the GI tract, one of the byproducts that it has is ammonia. So you're going to have this person that's confused. Not only is their liver bad, but now you're just helping them along with the process kind of thing. So the tube also allows you to get rid of that blood in the GI tract. So those are also people that you don't see it register right away, even though they bled all over the floor. If you did their H&H right now, it's not going to register. So yes, you're going to do it now anyway because it's an acute event that happened with the patient, but also make sure you repeat it because that's going to give you the true value of what is happening with the patient and tell you if you do need blood products or not. I will tell you, if you've never experienced in your life patients who are GI bleeders of any, we talk about varices or regular GI bleeding or rectal bleeding that are alcoholics, it has an odor like no other. I don't know what it is about alcoholics and their blood stuff, but it's just wrong kind of thing. You think C. diff is bad, it has nothing on that. You have patients that do that. So it can be a catastrophic event. That's why you want to make sure that if we find it in a patient, we treat it. The other thing that, and it's simple stuff that can cause it, even though we talk about anything that increases intra-abdominal pressure, that could be you getting jerked by a seatbelt. If you're riding in a car with somebody and you have a car accident, that could be patients who do not chew food well. So if you're eating nacho chips, you can actually rupture a varice if you don't chew up stuff well, because the vessel walls are that thin, so that you can actually cause that in a patient. The other thing we do if we know a patient has varices, even if they have a TIPS procedure, you always want to treat any upper respiratory infections quickly. Because that whole thing about sneezing, what do we try to do? I just did it now. What do you try to do? Not make noise? All that kind of stuff that increases pressure in your abdomen, so they could actually rupture a varice. So upper respiratory infection stuff is always treated quickly. You don't just let it go because it can end up causing problems for the patient. But it's not pleasant. That's one of those things that if you ever have a patient that does have this, it has a high mortality rate because of that whole issue about them rebleeding. And usually it's not witnessed. That's the problem. If somebody's there with you, they could save your life. But just remember, every time your heart beats, you're bleeding out. And unless you got an NG tube that you can blow up right there, you got a problem, kind of thing. But doctors can go in and cauterize them, put ligatures on them, those types of things, but the patient really does have to stop drinking. That's one of the major problems. Also on our TPN, on our section in here, we talk about TPN. Now, and also central lines, because that's also one of the things you have to do. It's one of the lab skills kind of thing is central lines. Patients who have any type of central venous catheter, You got to do several things. You know, they're put in because you're talking about a patient who needs long-term IV access. So that's not somebody, yeah, they're going to need it because they do a lot of things. You may be giving TPN, you may be giving antibiotic therapy, which you see with patients who have endocarditis that need it for that period of time. You may see it in a person who gets certain medications, chemotherapy drugs that are vesicant, so I want to do something that is not going to be peripherally, those types of things. So different types of reasons why your patient may need it, but all of them center around something being long-term. Some of them are implanted, which you have when you have ports, when you have Hickmans, those types of things. Others are just inserted peripherally. So that's going to be your central lines and your PICC lines, midlines, those types of things you see in your patient. Major thing you always have to think about when you have a patient who has any type of central catheter is that it has to be sterile when you're doing care to it, making sure that you clean things, all that kind of stuff, and you follow protocol for whatever your hospital says when you're changing things. Most hospitals and institutions use a BioPatch, which it gives you continuous antibacterial action that's going to your site when you're going to put in your central line or your PICC line, whichever thing that you're using for your patient. Okay. When you're doing a central line dressing, because that's what's in that you have as your skill, there is a video that I will put up for you that talks about central line dressing change. But one of the things to kind of remember when you're doing a central line is that everything that's close to the patient is sterile. Stuff you do on the outside you do clean. You and the patient wear a mask. Or if the patient doesn't want to wear a mask, they have to turn their face away from what you're doing. If there's family members in the room, they either have to put on a mask or leave. That's the way you look at it about doing their dressing changes. Okay, so they can get all bent out of shape, but they just have to go. That's just, you either have to wear something or go, kind of thing. But you will always wear one. Okay, and when you open up a central line dressing kit, there are 2 masks in there, one for you and one for the patient. I'm just telling you, that's the routine. So some patients will say, nobody ever makes me put one on. And I'll say, well, this is what we're supposed to do. If you don't want to wear one, you have to turn your face away from where I'm cleaning to do whatever it is I'm doing with your site. For you guys, it's a central line. I will tell you that most places don't let you mess with anything that has to do with dialysis catheters or that have to do with Mediports. They want specially trained nurses for that. Now, if you do it in your regular life, that's fantastic. But remember, in school, that's scope of practice kind of thing. And mainly because Mediports, if you mess them up, the patient may need a new one. So that's why if you don't know how to, somebody asked me one time, can you access this for me? I'm like, no. I said, I know how to do it. Done a procedure before in a lab, but not on a person, not been signed off for competency. Well, you can do it. I said, not me. Not doing that. I like my shoes. Curses too much. Shoes. That's outside of my scope of practice today. So always think those are things that people may ask you about doing stuff. If you don't feel bad about telling them, oh no, can't do that. If you end up working in oncology, that's part of your certification because most of their patients have ports. Mainly because that's the easy way for a patient to go home and do things and then come back and have access for us. But make sure there's going to be a kit. Look at what's in your kit. Some hospitals have everything in there that you're going to need to do your central line dressing. Some have things you have to bring. Okay, so BioPatch is one you got to bring. So that's usually in your central supply card. You also need the end caps because those things are usually not inside the central line dressing kit. And I will bring it over tomorrow so we can actually look at it and open it, but just kind of give you the idea about what you're doing with the patient. You're going to need, even though there's gloves in there, these do not usually fit in there, so I'll usually take me a pair of sterile gloves. And I'll take a second one just in case. If the patient's on isolation, make sure you leave the one outside because once you take it in, the patient owns it. Okay, so if your patient's on isolation kind of thing. So in your kit, there's going to be a couple of wands in there. One has chlorhexidine, one has the sealant to help it stick better. You're going to have an oxide dressing of some type that's in there that you're going to peel off and put on top. So what I normally do is I get all my stuff ready that I'm going to use for the patient. I tell them what I'm going to do, clean off my space so I can create my sterile field. Because this is a sterile procedure that you're doing with your patient. And so once I do all of that, I clean off my thing, I open up everything I'm going to need for my patient. Okay? I just leave it there. I open up my little containers and packages that I'm going to open, just so I open them and just leave them there for a second. And then I go over to put some clean gloves on and take off this person's, I don't take all the dressing off, but you know how you have to get everything and lift it up so that everything's in the middle and on top, because if you know everything sticks to the gloves that you have on, and you're going like, am I ever going to get this stupid thing off, because every piece sticks to where you're going on. So one of the things you can do is you're peeling up your dressing, always roll it on top of itself, because that way you'll just leave it right on top of the bio patch. So that's going to be covered until you get ready to do what you're going to do with your patient. So that's where I'll leave it for that particular time. So once I get all that ready to go, then I'll go back, put on another pair, because it's just me, I'm retarded this way. I open up my stuff, because I don't like opening and leaving over there, because I do that, I may contaminate my field. Get my stuff ready. Now I open up things, I drop the stuff where I'm going to open it and put this in, say my end caps, I put them in the top of my dressing kit that I'm going to use for the patient. Because there's always a drape in there that you're going to use. So I do that. Then I put on just one clean glove now and take off that dressing that's right on top of the bio patch. Then you have to look at and make sure your incision site or where the catheter is implanted, there's a lot of erythema, is there any drainage, all that kind of stuff that's going on. Okay. Then I'm going to put my mask on, okay, put patient's mask on. Then you're going to go and clean off the area that you're using with the patient, and you have to let it dry. None of that. People do that, and I'm going like, defeat the purpose. You're blowing on bacteria, stop that. So you got to clean that area. Now, we've always learned inner to outer, right? All the stuff now says you just go straight across and clean it. It's all right? So that's one of those things. And it's usually one of, most of the things now, instead of having those 3 swabs, we'll have one sponge, but you have to break the glass that's in there. And then you squeeze it to the front of your, the head of it, which is like a sponge, and then you just clean off. Let it dry. Then you have to put your bio patch on the patient. Okay? Now, when you look at a bio patch, it's silver on one side and white on the other side. Okay, one of them is eluting the medication that's on. So that's the part you put next to the patient. Then you're going to put your dressing on, and then you're going to put your end caps on. Now, before you put your end caps on, make sure you clean the outside. I always take, even though we don't use a whole lot of betadine, some places have chlorhexidine, those little small ones. You can use those, but if you don't, use betadine and alcohol. So what I do is clean the end cap, make sure they're off, they're clamped, but clean your area where you're going to put it together. Clean that, and I usually clean it with betadine. I wait for a minute, then I clean it with alcohol, and then I change my end caps. The end caps are the very end of that, the little ports you put on there. Then once you're done, I always just flush them after the fact, and then you're just date and time what you're putting on your patient. Some patients actually have things sutured in, and so nurses try to do a lot with those sutures. Don't even worry. Just clean them off with that, what you're using to clean the site. If it's very dirty under there, then just clean at the insertion site with your sterile thing, and then use an alcohol pad to clean on the outside. Because you don't want to be going from dirty looking stuff to clean stuff where your insertion site is. So you're going to date and time. Because you do a bio patch, most hospitals don't change those until every some hospitals have 4 days, most of them have 7 that they're going to change. Some hospitals actually have a group of people that only do central line dressing change. Their IV team does it. Does everybody do that? No. So it's in protocol for you to change them every 7 days. So just know that you have to look at those particular things. What you're looking for is that, and what you worry about when anybody has a central line is that, remember, they have a central place where bacteria can go in and you're looking for infection. If you have to take one out, because if a patient they're going to have one discontinued, and there's an order written for it, all you do is, if there's any sutures present, snip it around those areas, and then you're going to have the patient take a deep breath and hold it, and then pull it out. Apply pressure. And if you have anybody who's taking heparin or all those kinds of things, but you still at least want to hold pressure for 10 to 15 minutes, just because you don't want to, because patients can get pneumos from them. Insertion, but also can do it when they're taking them out if they're done incorrectly. You shouldn't have to do that incorrectly because it's not hard, but some people, I don't know what it is, you do all kinds of evil. kind of thing. So hold pressure there, and you tell the patient they shouldn't get up and move around for a little while, because we just do that as a precaution. It's not really that it caused the problem anymore, because you got anastomosis there. But then you just tape it over. When you look at the catheter that you pulled out, make sure it's smooth and it's intact. The one thing about anything in medicine that you put into a patient, it has a radial opaque stripe. So they're actually able to see things. That's how they can tell where stuff is when they're looking for something that broke off, is because it can actually be seen under x-ray. So but you're just making sure that it's smooth, and that's what they'll tell you, that tip is smooth and intact, because that's what you have to actually document in your notes when you removed it. Okay. When you have a patient who has a PICC line, if you ever see, you see people put them in, it's really long when you go to pull it out. And you go like, I can't believe all this is in the patient. It freaks you out sometimes because you know it's that far, but it just doesn't look like it should be that long when it's coming out of a patient. But the same kind of process you do when you're pulling it out and also changing the dressing. But the thing about PICC lines is that they're kind of, nurses tend to want to do them themselves. Nothing against you, but it's been kind of much, the central line is much shorter, so you see it and it's there. If there's a problem pulling out a PICC line, it's just like, it could be as long as 20 inches kind of thing. So that's why people worry about actually having students do those. So you will rarely have somebody ask you want to take out a PICC line? But you'll see them sometimes ask you about whether you want to discontinue a central line. What you can, it's not scary to do, but always make sure, that's one of the things that an instructor needs to be with you. Make sure that you actually look at the procedure, see what their policy in the hospital says beforehand. Now the other big issue, other than doing the dressing change, is that anybody who has a central line is at risk for infection, but especially those who have TPN. It's because TPN is a whole nother beast. We use it because it's total parenteral nutrition, or you may have a PPN that some patients only get part of the day, kind of thing. So it's one of those important things about optimizing patients' nutrition. So sometimes you'll see it cyclical, but for most patients, especially inpatients, we see it all day. So TPN is something that is ordered daily by a physician, or PA or nurse practitioner, whoever's ordering it for the patient. So every day they're going to write an order that said either they're going to change it because there's a form sheet that you have to order what you want on your TPN, or they're going to say continue saying TPN, and they may say change the rate, whatever it is for the patient. And it all goes by nutritional needs of the patient. So there's going to be a dietitian consultation to see how many calories this person needs. And then based on that is how they decide which TPN they're going to use as far as formulations. Okay? It always has amino acids because that's the protein part. It's going to have some percentage of dextrose. The dextrose can be 10%, 20%, 25%, or 50%. Okay? Only patients who have 10% dextrose can have it peripherally. And even then, you don't like to do it. So that's the maximum percentage of glucose that you can have in a peripheral IV is 10%. Okay. Now you will see sometimes doctors write orders and go like, give this to the patient. You go like, no, we have to have a central line put in. So 10% is the max you can do for a regular old peripheral IV. But most of the time you're going to see patients either get D25 or D50 in their TPN. Because that's where the calories come from, is the percentage of dextrose. Okay, so you have amino acids, and then you have dextrose. So you have essential fatty acids, and then you're going to get the sugar that you need to live on, kind of thing. All right? So that's the major component. So when you're talking about TPN. Then the doctor goes down and they look at, based on the patient's lab work and what they're doing, symptoms that the patient is having, either nausea and vomiting or that kind of thing. They have some oozing, fistula, whatever the needs are of the patient, they order the electrolytes piece. So those will be different based on the patient. So that's why daily lab work is important, because we look at what the patient needs. So you pretty much in your head think I'm going to see daily lab work for at least the first 7 to 10 days when a person gets TPN. Because after that point, people usually stabilize. Because that's the reason you have to do it every day, so I can figure out which of these formulations works better for you. So they will sometimes have 3 different formulations of one electrolyte. So don't freak out about that, because you know we're used to seeing just KCl in an IV, but you may have a person have potassium phosphate, potassium chloride, potassium acetate in the IV. So that's going to be directly related to what the patient needs. So you have whatever electrolytes the person has are going to be ordered. You also usually have a multivitamin, that's why it's yellow. You also have Pepcid or Protonix that is added to it. Okay, so all that is, and you're going to see that, it's going to be written on the order sheet, but it's also going to be on the bag when it comes up to you from the pharmacy. The other thing that you also see in it is insulin. Now remember, this person is getting either 10, 20, 25, or 50% dextrose. That's a lot of sugar. Your body's not used to doing that. That's also the reason why you have to do finger sticks on a patient who starts TPN. Never have been diabetic before in their life, but if I'm giving you TPN, I'm giving you more sugar than you ever eat. Okay, so until your pancreas revs up to cover it, that's why the patient ends up needing coverage. You ever notice when a person's on TPN how they need a lot of insulin at the beginning and they start needing less towards when you get their numbers right? And that's because your body now takes over for giving you the amount of insulin you need to cover what you're getting. But your body has to ramp up for that. Now, patients who have pancreatitis or diabetic patients, you always going to have to give some insulin, because guess what happens? Their pancreas isn't working like it's supposed to. Diabetic already doesn't have that, so you will give those people insulin all the time. But I will tell you, you'll notice that you'll start giving less and less every day when you're talking about giving insulin to the patient, or they're getting less coverage because they're adding it to the IV. So when you have a patient who's going to have TPN, that's the first thing they do. They might also order lipids for the patient. Lipids are true fats that you're giving to the patient. So that's a small bottle, has 500 mLs. They also have a bottle now with 250, because some doctors have now started ordering 250. You need some fat, but you don't need as much as that. All right. TPN is usually ordered in the morning, made in the afternoon, delivered to your floor in the evening. So TPN is something that is hung by nurses on night shift. In general, that's been pretty much every hospital in our area. Requires 2 nurses to identify the information that's on TPN, just like you do a blood product. So one of you is reading it off, one of you is looking at the order. If everything is there, both initials go on the bag. Tubing for TPN is changed every day. So you might as well just get your tubing set you're going to need for this patient. So they get regular IV tubing, but they also get a filter that goes at the bottom of your tubing. So you know how you add an attachment? So it's your regular IV tubing up here, the filter goes before the patient. That's how you always remember. Filter fits just above the patient. So it's something that's screwed into the end of your IV tubing, and then that end is then screwed into the patient. You always want to make sure you prime that before you go in there, because one of the things that happens is, even though that filter looks like a little innocuous thing, it takes a long time for all the fluid to go through. So you go through, fluid goes through fast through your regular IV tube, and you're like, man, it's taking forever, because it has to fill up all the pores and make it through. So it takes a little while to do that. It's kind of slow. It looks small, but it does that. After you do that, that's the part that gets attached to the patient. Now, if they have a central line, usually 3 ports, sometimes they're 4. We usually put TPN on the blue. If they have IV fluids, or if that blue one is clotted off, we put it on white. Those colors are just like the regular IVs. The blue is the smallest. But there's nothing that should be going with TPN. It should always be something that's standalone, by itself, not interrupted. The only thing you ever hang with it is lipids. And that the lipids are going to go, because one of the things that you did when you put that filter on, it also now has another piggyback port right before it gets to the patient. So if you have to hang lipids, that's where it goes, below the filter next to the patient. You draw a picture. So if you have your regular IV tubing here, okay, then when you get this little filter tubing, it's going to be so this is the cap here, So your cap from the filter is going to fit there. But in here, you're going to see some tubing. There's going to be some type of filter here. And then you're going to have a port right here where you can actually add something. And then that's going to go to the patient. Okay, so this is my filter. This is my last port. And then this is the patient. When you have lipids, if you hang anything up here, because you know there's always a port right here at the end of the tubing, if you hung it there, it would clog the filter. So that's why lipids go after the filter. Yeah?
Why do you need the filter?
Because there's always something that they filter out of TPN. Even though it's done under, because they worry about particulates and that kind of stuff because of all the stuff they mix in it. Plus it hangs for a day. It hangs for a whole day. So when you have patients who have it, that's one of the issues that sometimes happens. And when you have patients who have TPN, it's the one area in the pharmacy that's done under halogen. They go into a clean room to do TPN. Everything is under a shield, that kind of stuff. It's considered, you know, a sterile kind of thing when you're adding all that stuff to TPN. But what you worry about is particulates that can sometimes happen because this fluid hangs for a whole day. So you're going to get a big old bag. And depending on their rate, that's how big your bag is going to be. So if you got somebody doing 125 an hour, they're mixing enough for them to get 125 for 24 hours. Okay, so it's a large infusion bag that you have for your patient. So once that TPN runs continuous, your lipids usually run for about, and most times, Dr. Wright, you run them at 50 an hour. So they usually are done by the time night shift is over. So you're taking them down by 4 o'clock in the morning. And then your TPN is the only thing that runs. But you're not supposed to interrupt TPN. It's supposed to be continuous, mainly because once you put it on continuous and your body is now making insulin all the time to cover that, when you disconnect people, you can cause people to go into hypoglycemia. Nurses make me crazy disconnecting patients from stuff that all you need to do is roll the pump. There's a reason why you don't do these things, but they do it anyway. But you should never interrupt TPN for that reason. Say you didn't get a bag from the pharmacy. You're still waiting. It's 2 hours late. Nobody can find it. It's in the tube system somewhere. Dead. You don't know where it is. Kind of thing. What they tell you to do is lower your rate of infusion because that person needs to continue to get glucose all the time. So instead of being 100 and 125 an hour, you might turn it down to 75 just to give you time to get a new bag done. Because you don't want a person to be without it. Now, when you get a person that you're going to take them off, because remember, this is something that's supposed to help your nutritional status, help you gain weight. Those are also things that are going to help me as far as if I have to do surgery on a patient, it's going to help with healing, that whole thing about them getting better after the fact or whatever I'm doing with them as far as surgery or whatever is going on with the patient. Those are things I want to make sure I do. So when I have that happen with a patient, TPN is something that I'm going to continue to monitor. And like I say, you do finger sticks initially. Sterile dressing changes are the things you want to do with your patient. And you will notice that if they're in the hospital for a long time, you will see the doctor say just do finger stick in the morning and afternoon instead of doing them every 6 hours. Patients on TPN should be weighed daily. That's part of protocol. Those are sometimes those things that if you don't do them, your hospital can be caught and you're saying that they'll go back and the insurance company can say you only weighed them 5 days of the 40 days they had TPN, so I'm only going to pay you for 5 days. Insurance companies have done that. They're saying if you don't follow your protocol, why should I pay you? Those are the kind of things they do. But don't interrupt it for antibiotics, all that kind of stuff. On the rare occasion, if you have a person that has clotted off all the ports except one, and that's where TPN is going, there are things that can run, but it also has to go below the filter. So, but that stuff you have to look up, the pharmacist has to find out for you. And if they have to mix it in something else so that you can do that. Because there are some antibiotics that are compatible, but it always has to be done at the lowest port. But you never stop the TPN, you just let it runs with it together. But you try not to have any of that going on.